While both are named after the same person, the Aslanger pattern and Aslanger sign describe entirely different phenomena on a 12-lead ECG. One is a critical, life-threatening ischemic event, while the other is a benign mechanical artifact. Here is a breakdown of the underlying pathophysiology, ECG characteristics, and clinical implications of each. The Aslanger pattern is a true ischemic signature that indicates an acute inferior occlusion myocardial infarction occurring in the presence of severe multivessel coronary artery disease. Because it lacks contiguous ST segment elevation in leads 2 and AVF, it frequently fails to meet the standard STEMI criteria and is dangerously misclassified as an NSTEMI. Patients presenting with this pattern typically have an acute occlusion of the right coronary artery or left circumflex plus critical stenosis in other vessels, often left main or severe 3-vessel disease. Inferior MI vector directs inferiorly and to the right. Diffuse subendocardial ischemia vector directs superiorly and rightwards towards AVR. Resultant vector, the summation shifts the overall vector sharply to the right. It projects strongly towards lead 3 and AVR while effectively cancelling out the expected ST elevation in leads 2 and AVF. Diagnostic features: ST elevation isolated to lead 3, lacking contiguous ST elevation in 2 or AVF. ST segment depression in any of leads V4 to V6, featuring a terminally positive T wave. The ST segment in V1 is higher than the ST segment in V2. These patients have a high rate of cardiogenic shock, larger infarct sizes, and increased mortality. The Aslanger pattern should trigger emergent cath lab activation for rapid revascularization, bypassing standard NSTEMI medical management. In stark contrast, the Aslanger sign, also known as the arterial pulse tapping artifact or electromechanical association artifact, is a completely non-ischemic phenomenon. This artifact occurs when limb electrodes are placed directly over or too close to a pulsatile artery, such as the radial or posterior tibial arteries. The mechanical pulsation of the artery physically taps the electrode. Because the arterial pulse is mechanically tied to cardiac systole, it generates a rhythmic voltage disturbance that is perfectly synchronized with the cardiac cycle. It presents as pseudo-repolarization abnormalities, commonly mimicking TP segment downsloping or upsloping, ST segment shifts, or prominent U waves. The distortion is usually observed in multiple limb leads, but classically spares one, typically the lead acting as the reference point for the exploring electrode. It is more common in hyperdynamic states where the arterial pulse is bounding. The artifact resolves immediately by moving the limb electrodes away from the arterial pulse points. Example, placing them higher on the forearms or calves and repeating the ECG. Here is a comparison. Origin: Aslanger pattern, true cardiac ischemia, acute occlusion myocardial infarction. Aslanger sign, mechanical artifact, arterial pulsation. Underlying pathology: in Aslanger pattern, it is inferior occlusion plus severe multivessel coronary artery disease. Aslanger sign, none, electrode placement error. Key ECG finding: isolated ST elevation in lead 3, ST depression in V4 to V6 in Aslanger pattern, while it is distorted TP ST segments time locked to systole in Aslanger sign. Clinical next step: emergent angiography or reperfusion in Aslanger pattern, while in Aslanger sign reposition limb electrodes and repeat ECG.